Welcome everyone to the September 10th, 2020 COVID-19 clinical care rounds, emergency department patient care and clinical operations. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 emergency department challenges and successes. If I'm preparing my emergency department for COVID-19 patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Strumminger and his team for the peer-to-peer learning platform we use for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Mondays EMS, Tuesdays critical care, and Thursdays emergency department. It is self-evident that our nation's medical response challenges are continuing to change every day. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. For example, today's session focuses on challenges faced by frontier and rural areas. For the ECHO rounds, we continue to have participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and the NETEC's webinars are complementary to each other. Thanks to the American College of Emergency Physicians, the Emergency Nurses Association, and the American Association of Emergency Nurse Practitioners in their support of these rounds. We received many questions for each of these rounds and apologize in advance we're not able to answer all of them. We do select some themes from the questions received and hope to cover some of those. Then I'll turn this over to Dr. Bruce Strumminger.
Thank you, Rick, and welcome to Ann Zink for being our guest presenter today, and to our expert panelists, and most important, to all our participants who are joining. I'm just going to go over a few logistic and housekeeping items before we get to the main event. We really appreciate your questions and your comments. So please, there's a Q&A function in the bottom Zoom toolbar. Put your questions and comments about today's session there. If you have any technical or logistic issues you need help with, mention those in the chat function. Also, Rick will be asking a crowdsourcing question in a few minutes, and the chat space is the best place to put your response. We are recording today's session, and your attendance is consent to be recorded. Thank you for that. Today's presentation by Dr. Zink is linked to the most recent email that went out today, and will be also on our website, and today's recording will be up within a couple of days, and we'll share a link to that website, which has recordings of all the sessions from the last 6 months and the PowerPoint presentations related to those. We are offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based. And we'll be putting a link in the chat about 15 minutes before the end of today's session. We really appreciate your feedback. There's a short survey, and it takes about 3 or 4 minutes to complete. That's how we learn from you about what topics you want to focus on over the next, in the near future and medium term, and helps us to do quality improvement related to this clinical round series. These learning sessions are focused on improving patient care and health systems and supporting clinicians. Let's keep this a political-free zone and also a commercial-free zone. And we thank you for your cooperation with that. Data use, just a word, when you register, when you participate in the polls, when you answer in the chat, that's all data. We just want to ensure everyone that we're stewarding your data carefully. And we do share de-identified data with Rick and Asper to create reports for leadership as they respond to the COVID-19 pandemic. But we keep your data very carefully. Just want to say a word about the NETech Education and Training webinar series. Sharon Van Aersdale is usually with us from Emory to give us an update about this. They have a regular series of webinars, and tomorrow they'll be presenting on palliative care during the pandemic. But there's an ongoing series, and please visit their website to both be able to access recordings of prior sessions and see what sessions are coming up this week and in the near future. Also, the AAMC is a partner in these clinical rounds. They've developed a fantastic COVID-19 clinical guidance repository. They update it weekly, so we encourage you to visit that site and take advantage of those resources. So Rick, back to you for the crowdsourcing question.
Thanks, Bruce. Try to stay focused on patients and certainly the health of yourselves and fellow clinicians. It struck me that we haven't actually focused on the patients recently with the rounds, and it seems appropriate to ask the question, what is your #1 clinical pearl in taking care of COVID-19 patients in the emergency department? It's been a long time since we started rounds in March. It's been quite the roller coaster, and our experience with patients has evolved phenomenally in the past 6 months. So if you could please respond to that one, I think it would be helpful to everyone to know what's working the best in caring for patients in the emergency department right now. If each of the panelists could please take themselves off mute, and we'll go around, and if you could introduce yourself with name, title, and affiliation as usual. Sandy, maybe not Sandy yet. I'll go to Thompson. Dave.
Hi, I'm Dave Thompson. I'm a clinical professor of emergency medicine at East Carolina University and the medical director for Vidant East Care.
Great, thank you. Sandy.
Hi, Sandy Schneider, Associate Executive Director at ACEP for Clinical Affairs and a practicing ED doc in Fort Worth. Sorry, I couldn't get off mute.
That's fine. Yeah, that never happens to me. Juan.
Good morning. My name is Juan March. I'm a professor at East Carolina University at the School of Medicine and also chief for the Division of EMS, board certified in both EMS and emergency medicine.
Thanks very much, all. And Harry Seibold may be here for some of the rounds, so I don't see him on the squares right now, but he's around if he's not jumping into a fire right now. So
up here.
There you see, on cue.
So I'm Harry Seibold. I'm an emergency and EMS physician from Helena, Montana. I'm the past state EMS medical director for Montana. Sit on air medical committees for ACEP and NMSP, and I'm on assignment with the U.S. Forest Service on Central California fires right now.
Thanks, Harry, for joining us. I know you're busy, all of us are busy, but you got a particularly big challenge right now. With that, I'm going to introduce our speaker, and it's an honor to meet and introduce Ann Zink. Dr. Zink is a fellow emergency physician and state medical officer from the state of Alaska. Really look forward to hearing from you. Ann, please, over to you.
Great. Thanks so much, Rick, and good morning, everyone. Yeah, so I'm Dr. Ann Zink. I am the Chief Medical Officer for the state of Alaska, but more importantly, I'm a practicing emergency physician. I've been practicing in Alaska for 13 years, came up here because I used to guide up here, and my husband said, I did residency for you, you can do Alaska for me for a few years. And I said, they're crazy up there. I'm not sure I want to go work up there. And I came and I loved it and I stayed. It's an incredible place to work. This hospital I work at takes care of an area the size of West Virginia. We see about 32,000 patients a year. And I love just the interaction with patients and having to figure out what really made sense from the data and science. You know, we discharge intracranial hemorrhages all the time. What you're doing with back fractures, we're going home. It wasn't like, well, these people just went to the ICU because that's what our protocol does. It was, what does the data and science really show? And what do you really want to do for that patient? What does that patient really want? And I really love that aspect of it. I also loved the sense of community and that it was a community trying to figure out problems. And we really saw that around the opioid epidemic. When I came up, it was really starting to take off. And through the community and community partnership, we made a huge difference in opioids overall, and we're able to really partner, see a significant decrease in overdoses. We really changed how we were prescribing in the emergency department and became very involved in that epidemic and pandemic, and it was just really meaningful work. I started to just ask more questions. I really found that in the emergency department, all public policy came to fail, and I was going to get burnt out if I just kept tolerating the same psychiatric patient sitting in my emergency department for a week on end. And that if I really was going to stay in this job a long time, I was going to have to figure out solutions to the problems, not just continue to rubber stamp the same problem over and over again. So I started to get involved in meetings, maybe too many meetings. And last July, I got asked to step in as the state chief medical officer. Dr. Jay Butler, who was in my position before me, got asked to be the deputy director of infectious disease at the CDC. We'd gotten to know each other throughout the years, and he was kind enough to recommend me when he moved to the CDC. And it was kind of always my dream job. I did tell Jay, I said, you know, before I die, I want to be like you. And I wasn't really meaning now. And so I wasn't really thinking this was going to be my career path, but it seemed like an opportunity that I couldn't say no to. And so last July I said yes. I was also not necessarily expecting a pandemic to then shortly follow thereafter, accepting the job. So I remember very clearly in December having lunch with Jay. He got a call and we were on the phone, and he said, oh man, this really sounds like a coronavirus in China. I'm really worried about how this looks. And this was before the first case was announced, and he was part of the team trying to figure it out. So life started, and we have been challenged with the have been in the state, and I'm honored to just spend a few minutes talking a little bit about Alaska's response to COVID here in the state. It really comes from my perspective as an emergency medicine physician. I think the biggest thing I've learned is that the skills that we have in emergency medicine are critically important to public health, and we need more ER docs to come into this world of public health. We're really good at not having all the answers and at figuring out how to work with limited resources, and that has been the pandemic. And so figuring out how to do things quickly. I remember having this great conversation with IT, and they said, well, you know, we've scheduled out the response and we should be able to get there in 6 months. And I said, awesome, have a conversation with the virus, you two get together. And if you're on the same page, I'm on the same page. But in the meantime, it seems to be spreading faster than that. So what can we do to move forward? I think in emergency medicine, we are used to that, and we're used to finding ways to respond. So I'm going to switch over to my screen and just go through a few just pictures, a little bit of history about Alaska. Can you guys see that okay? Thumbs up. Yep. Okay. Sounds good. I'm going to assume you can see those slides. So again, this is, I'm Anne, and a little bit about COVID in Alaska specifically. So there we go. So just, I think it's hard to talk about our response without talking about the people and the land. It's hard to kind of put it in context without talking a little bit about that, a little bit about responding to COVID, and then some of the lessons learned for myself as well as our team, and then next steps moving forward. So the people and land really define us in so many ways. We're an incredibly geographically and humanly diverse state. And I think it's one of the things that I absolutely love about it, but that has been a real challenge as well as asset as we have found ways to respond to COVID. This is one of our favorite maps. In fact, our state cards have this on the back of our map. We really like to show how big we are compared to other states, but it is really important to notice just how large it is. When I'm trying to think of getting a swab from way out in the Aleutian chain out there where it's kind of on California to say Anchorage, which is, you know, over towards the Midwest there, it can take a really long time, even if the weather is good. So it's just a huge state when we're thinking about transport and tests and turnaround times. We are larger than if you combined Texas, California, and Montana. We're the least densely populated state in the nation. 60% of our communities are only accessed by small planes, 11% by jet, 8% by highway, and some limited road system as well. So planes become a really big part of what we do. Our entire internal main state airlines collapsed within a week of COVID starting because of bankruptcy. And so suddenly our normal way to get to and from all of our villages and how we transported supplies and people and resources was completely gone. So not only did we have the pandemic, but we lost most of our transportation within the state in a short period of time. We also have a series of kind of healthcare networks that sit on top of this. So this is the Alaska Native healthcare system and the referral patterns. This is hugely important to the care that we deliver in the state. They were the first trauma center in the state. When I first moved up here, the only place you could transfer a trauma patient to that was a trauma center was the Alaska Native Hospital. There was no private trauma system. And they've done a fantastic job of just really elevating the care of Alaska Native people. And it's been critically important for both Native and non-Native people. And so we have to really make sure that we're working in collaboration. And a pandemic is a little bit more challenging because they get some support specifically from IHS. And then there's the typical HHS and ASPR kind of support. And so we're always having a lot of conversations back and forth to make sure that people are supported wherever they are and regardless of how that support is coming in. We have 229 federally recognized tribes in Alaska. They're about a fifth the population. We have villages that range anywhere from 12 people to 3,000 residents. You can see that it's predominantly Alaska Native people in those regions. And that has all sorts of impacts on both COVID as well as testing and supplies, but is important to note. And also, you know, there's a federally recognized nation-to-nation agreement. And so as a state, we're oftentimes kind of a third wheel in that party. Here's our road system. It's not much. So we have a little bit of road around here, but you can see that most of the state is completely off the road as a whole. Telehealth is incredibly important. These are these Afghan stations that particularly the tribal system uses in many of our remote and rural locations. They're super cool. Put EKG on it, you can look in people's ears. We're at the very beginning. Community health aides are a big part, important part of our health network out in these communities. They're usually high school trained health advocates essentially in communities who get health training, and they have like this book that helps them to kind of know what to do and what to look for. We created a COVID health aid training early on, and we also use telehealth for doing swabs. So the healthcare observer swab will oftentimes just have the healthcare provider on the phone or on the Afghan, and the patient or our patient's family will kind of self-swab and then send it in as well. So what ways can we use technology to really get healthcare to absolutely everyone in the state, making sure that everyone's got access to testing and knowing what to do if they had a COVID patient as well as other diseases. The military is also a really big important part in the state. Many conversations with Coast Guard and others about, can you fly the swab or where are you going next? Particularly when the initial airlines, the Raven Airlines went down. And so the relationship and partnership with them is really, really important. They have a completely different IT system. Their reporting for information, their vaccine distribution is different. And so working with these federal partners is just really important in the state to make sure that we are all collaborating together. It can't just be a side thought. It has to be an integral part of our planning process. And then just really in the Alaskan context, there's just this incredible connection between health, income, place, and race in all sorts of ways. We really live in these beautiful remote communities, and we see this affect people's health in all sorts of ways, but it's really important in the way that we think about treating and dealing with COVID. So how do we respond to COVID? What have we been doing? I think it's important to also remember the history of Alaska, and this came up just front and center at the very beginning of this pandemic. The Alaska Native people suffered tremendously from the 1918 pandemic, and whole communities were essentially erased by the 1918 pandemic. This is a picture of orphans from the 1918 pandemic that just, again, decimated certain communities. Dillingham, where there's a hospital, it's a big part of the fishing. We were talking about fishing earlier. The hospital is actually built in the orphanage that was made to house people from the 1918 pandemic. So when we saw this pandemic coming, we were seeing just the tremendous devastation, particularly in the Navajo reservation. This really was very front and center in the Native communities in our state. And what is this going to mean for our state? And how are we going to respond? In fact, the 1918 influenza virus was actually cultured, and it couldn't be grown, but actually got sequenced from a woman who had been buried in permafrost up in Alaska. And communities that were hit really hard by the 1918 pandemic lost a lot of culture, a lot of history, and a lot of language. But other communities completely barricaded their roads with, essentially armed people and said, you can't come in, and those ones survived. And so what we saw was a very similar kind of process here. Again, the kind of initial deaths. Oh, I took a picture of it out. At the very beginning, we saw many of our Native communities completely barricade off. No one comes in, no one comes out. And this is how they're going to protect. This pandemic's longer than the 1918, and it's you can't, keeping food out, keeping other medical supplies in and out, pregnant women who need to deliver in a city, things like that. So we've had to kind of work through some of those challenges, but I think it's been really important to just remember that past, recognize and honor that past, and find ways to move forward with this pandemic, and recognize what tools do we have that are really different than 1918, and what things, unfortunately, are very similar. Unfortunately, the Alaska Native people have been hit somewhere between 3 to 5 times as hard with every single pandemic that has come through, including the H1N1 pandemic that came through. So it's not that this is just in the past, it continues to be present. When you look at the risk of COVID complications, this is from the MMWR, you can see the bottom one I don't pay as much attention to because that's based on density of population, but the top one is based on your percent of people that have it. So again, when it has to do with percent of total population, we don't even make a blip in the radar of things. So I look at the percent of population. But you can see particularly that really western side is where we have more people with chronic disease and underlying medical conditions, and that is much farther away from healthcare and not accessed by any road. So where have we been? What happened in this state? So initially, we were watching like everyone else. We flight from Wuhan, that actually the repatriation flight came through here. That was quite the time. Landing, did screening. It was fascinating to hear conversations of, well, if anyone's sick, just leave them in Alaska. It's cold and isolated up there. We were like, wait a minute, you can't just leave them here. Like, we really limited healthcare infrastructure. It's not going to work. So there was a lot of conversations about what do we have and what don't we have and what was going to work. But fortunately, that went off okay. We stood up our emergency operations center 3 days before that, and we've been in our emergency center response system since that time. So it has been a long haul of being in that emergency response. We saw our first cases come from cargo pilots. We are the busiest. We are now the busiest. We were the second busiest cargo hub in the world. And so we get a lot of cargo pilots who come through. And then we started to get some travel imported cases, interestingly, from patients who had been admitted in Washington state and then discharged home, then came home for rehabilitation. And then that's a lot of how our community spread got started. So just that nosocomial spread in other cities and how quickly that took off in our state. We had this kind of first wave, like many places, we said, okay, what can we do? We need to get more testing. We need to shut things down. We really struggled with supplies and resources in the state, as many people were, as I'm sure many of you guys remember and experience, like if you weren't the place with the highest percentage of cases or the most number of cases, you didn't get supplies. And so we were regularly told by most industries who are doing any testing and or manufacturing swabs, we're never going to be able to supply to you because you just don't have that many people. And so we want just sheer numbers, and you don't have a lot of people. So that was a real challenge for us. I remember at one point we had 6 swabs in the state that we could find. We were like up at midnight trying to go through like every doctor's clinic to see if we could find any more swabs to get them over to the hospital to be able to run them. And we knew early on that in Alaska, we'd have to figure out a lot of this on our own. So we started to manufacture our own swabs. We opened up a 3D printing company and started to make our own, had some fascinating conversations about PPE and other things. Those printing of the 3D swabs was hugely helpful. We also found that Fish and Game does a lot of RNA PCR. So they had a lot of machines and techs that could help us. So we kind of commandeered many of the Fish and Game. We started to make viral UTM at our Sea Life Center, which actually got started as part of after the Oil Valdez spill, because they had the ability to make UVM and UTM. So the veterinary world was very helpful in that. And so we really just had to kind of figure things out on our own for quite a while. And that was hugely helpful. That was a brace and a bridge for us to be able to test. And so we had this kind of like first little wave lit, and then it kind of went down. We identified cases, contact traced, and they went down. We went almost 3 months, 2 months, 3 months with like 0 cases, 1 case, 2 case. We were apparently open, and we were totally open during all that time. And it was a little nerve wracking because you're like, oh, it could get worse again. But it was also like, we really just did not have many cases. Our big challenge during this time is that we were getting between 40 to 50,000 seafood workers internationally, all coming up, going to these areas that had been most devastated by the 1918 pandemic and living in close settings. So we were working super hard to try to keep those from breaking out. We created mandates that required testing and quarantining prior to going into those, kind of similar to what the NBA is doing now. It's funny to listen to the NBA in their bubble. And I'm like, yeah, that's what we've been doing for fishing all summer. So we essentially created fishing bubbles that were clean and clear prior to going in. And it was fairly successful. We were able to get through the fishing season. We did have a couple outbreaks. The biggest outbreaks resulted in from community members then getting it and bringing it in rather than people being imported into the state once we started to get more cases in the state. And then we had one big outbreak on a vessel that is still under investigation, I guess I'll say. And so we did have a couple big outbreaks associated with that. But for the most part, particularly after watching the meat and seafood processing world, it's been okay-ish. We do have these alert levels. We really struggle with data in the state. You know, if you have 10 people in a village, how do you calculate, you know, cases per 100,000 that's meaningful and compare it to other things? And so you have to just really kind of move and be responsive and reflexive. We have 17 different echo calls that happen around the state. One of them is with municipality leaders to help them create kind of their own metrics and guides that are more relevant to them. These are our behavioral health regions that look at normal care and movement of patients as part of a behavioral health 1115 waiver that we did a while ago. And so those are alert levels because they have at least 20,000 people in each of these regions. And we define them as less than 5 to 10 or greater than 10 new cases per day per 100,000 people, average over 14 days. You can kind of see we'll have these mixes. Spent a lot of time finding ways to get things around the state, as I mentioned previously. So these are samples being sent in the nose of a plane. So oftentimes using other pilots, fish boxes do a really good job of keeping things frozen. And so we use a lot of those fish boxes for sending samples. Spent a lot of time getting PPE, had a lot of PPE requests that we had purchased get bought out from underneath us by bigger states who could pay more. So we would like secure a large PPE and they'd be like, sorry, California got it. And you're like, okay, we'll start again. So just really interesting to see how that whole process worked from a small state component, but we're able to secure PPE. This is our contact tracing and testing teams. So four-wheelers are a big part of what we end up doing to get out to some more remote locations, as well as small planes and boats. But having kind of that culturally relevant on the ground response is been critically important, particularly as we've started to get cases in our more rural areas. And I can talk as much as you guys want about how we do some of our contact tracing and rural testing, because that's been a really key component of trying to minimize its impact in our most rural areas and try to keep it out. Of note, most of our hubs are doing airport testing, and at the state we're doing airport testing. So we require a test 72 hours prior to coming in or get tested when you come in. And then additionally, most of our hubs require testing to come in. And most of our hubs, about 50% of their cases have been identified by airport testing. And so that kind of initial screening testing has been a really key aspect in identifying cases early. We've been able to keep up in contact tracing throughout the process. There have definitely been some hiccups. Having a IT system that connected all of us was incredibly important. Working in the state, it's made me realize that EHRs are fast and easy compared to state IT. I have a whole new appreciation for what slow really can look like. But we are now have an IT system that allows us to use our contact tracers from around the state to support each other as we kind of see outbreaks in different places. Things like hand sanitizer were really hard and super challenging, but really important. 32 of our communities don't have running water or sewer. So if you say wash your hands, it's really hard if you don't have running water. And so what does that look like? We did start to manufacture hand sanitizer like many other places, and then it's a flammable ingredient, and so it's really hard to transport. So we ended up using the military to help us transport hand sanitizer to most of our rural communities to get that out there. Culturally relevant information language, I think, is always important, and you can't communicate enough during a pandemic or really any time in public health. And this has been really important as ways that we're able to communicate via radio or telephone or Facebook in some of our communities is huge. And really using trusted community leaders to help share messages and communicate. As I mentioned previously, ECHO has been hugely helpful for us. They actually called us early on and were like, you want help? We were like, yes, please. And so we have 17 different ECHO, one that started up with vaccines. We did ones with fishing. We have ones for healthcare providers, now schools, teachers, science echo for the public. There's a whole bunch of echoes that we do on a regular basis to try to provide two-way communication. We have one or two of these a day that are shared nationally. And then we have these clinical updates where we kind of just summarize the literature. These go out about 2 to 3 times a week. And these were done by a resident who just kind of stepped into the process, and we found her. She was doing amazing work. We're like, will you help us more? And so she has been helping us and it's been great. So that's where we're at. We're doing okay. So right now we're the most tested per capita on most days. We're always in this competition between Rhode Island and us. We kind of bounce around between kind of the most. We really have been from the very beginning felt like having access to testing was our way to have a flashlight on this pandemic and was critically important. So we just put a ton of time and effort. Our state lab does somewhere between 2,000 to 3,000 tests a day at our lab, just because we could not count on the commercial lab space to be able to respond at all. So most of it is done in-house. And then we did independent validation studies of the Abbott Now, and we have probably about almost 200 Abbott Now ID machines around the state in different places so that we could do more point of care in real time. And we've actually seen really good results and data from that. So we continue to watch the cases. We've been kind of bumping up and around. We're kind of this really annoying steady state right now and continue to just push these outbreaks as a whole. And then watching our deaths has been incredibly important. We're fortunate that our deaths per capita are the lowest in the country as of now, but we're a long way from this. And so that, to me, that's my end goal, right? Like how few people can we have get sick? How much can we promote health and wellness? And how few people can we have die? But it's also meant that our communities are kind of spoiled. They haven't experienced it. They don't know it. And when I talk to my ER colleagues from around the country, we've just had a very different experience up here than some other places, having access to PPE and testing. And so the new challenges of I think we're all fighting COVID fatigue right now, but how do you fight COVID fatigue in a state that really has not had to have the brunt of it in many, many ways? So that's what we're working on in many different components. I would also just mention that we unfortunately are starting to see, as we've had more cases, racial disparities start to show up in our data. And specifically the Pacific Island community got hit pretty hard here. So these are our number of hospitalized by race. So Pacific Islands on the top, about 17% requiring hospitalization statewide. About 4% of our cases have required hospitalization. In general, we have a younger case mix compared to most other places in the state. And I think it's just because we've had more access to testing. So we've been testing younger and healthier people kind of from the beginning. And then here's our deaths by race. And so while the Native American population makes up about a fifth to a quarter of the population, 13 of our 36 cases are amongst Native American population, Hawaiian 4, white 15. So we're definitely starting to see some discrepancies there as well. So lessons learned, learning from this past. So these were the villages that kind of shut things down early. That communication, that two-way communication, particularly with our tribal leaders and our local leaders, has just been really, really important and something we're continuing to move off of. This pandemic has really, I think, just challenged us all on a traditional response versus prevention. And so as we're months into it, how do we make sure that communities can get running water and hand sanitizer and sewer and things that really are part of prevention, but are really important for COVID, but aren't a part of the traditional emergency response. So this kind of gray zone between the two. So we've been working with HUD a lot on that. Really creating that structure for two-way dialogue. Vaccines is our next big challenges with everyone else. Again, that response versus prevention. Data sharing, I mean, most of our labs were initially coming in via fax. We had just mountains of fax labs, and we still get a lot of fax labs, but trying to work through that and then that communication and relationship. And then I oftentimes bring up this last slide. I feel like this is much like COVID. This was a blanket toss, a traditional native fun game, but all of us have our hand on the response to COVID. And if any one of us lets off, this person falls, and we're all jointly responsible. So what ways can we all stand into that space together? And so my last little plea to emergency docs out there is that we have a real skill set that public health needs, and your skill set to be able to prioritize, to be able to look at what resources are there or not there, to think about each person, regardless of their ability to pay to come in, it is really needed. And I'm just so grateful for my emergency colleagues around the country and state who we continue to learn from on a daily basis, and encourage as many as possible to think about this kind of crazy and fun other emergency world of public health. So with that, I will pause. Thank you.
Ann, thanks. I learned a lot. Thanks. I mean, it's a wonderful presentation. Yes, the photos were great. The telehealth piece in particular. We've, throughout the rounds, talked about the use of telemedicine, telehealth, but glancingly. It strikes me, and Bruce noted in a text to me, you in Alaska are real leaders in being able to apply it. So if you could talk a little bit more about telehealth, telemedicine, how you're using it. In particular, I'm thinking about, okay, so you have emergency departments, you get the primary care docs, you have critical access hospitals, and then, okay, which meccas are you like, are the centerpiece? I just talk a little bit about that network and how you're using telemedicine would be, I think, really helpful to a lot of people that are still trying to figure it out.
I think it really depends a little bit on where you're working. So if you're working within the Native system, they've done an amazing job of building up telehealth for some time. So if you're working in the Native ER, you may get a call from a village elder or a community health aide in some village, and they're like, I got this 80-year-old who's got back pain. What should I do? And you're like, is it a dissection and I should, run a helicopter, or did they just get a moose and they're sore? And so they have gotten actually really good at trying to kind of figure those things out and kind of do this risk-benefit analysis, and I think have done just a great job of building that up. I think having those kind of pieces along the road for telehealth is really important. I think they've done a great job of that as well. So as I mentioned earlier, like those community health aides, like, can you check a sugar? Can you check this? Here are these things that you need to know in a physical exam. That makes telehealth just that much more useful and important rather than you having to do it all on your back end. So I think not just thinking about how do you make the connection, but how do you make the connection with someone who knows how to at least do the exam or something else on the other end is really important. I think they've done a great job with that. I think the private sector has been a little bit harder at that. We don't have a county hospital. We don't have a public hospital. We have a bunch of kind of like independent hospitals around. Most of them work as referral centers. And I would say that in general, it's not been as structured of a telehealth response, particularly for an emergency response. It's been a little bit more hit or miss, but a lot of it has been physicians standing into the space. So for example, our neurosurgeons regularly will look at images with you in the emergency department and say, yeah, that, I'm comfortable sending that home, or that's a completely devastating head bleed. There's no point in transferring that patient. Can I talk to the family? And you just hand the phone to the family. They've looked at the image, they consult each other, and then you admit the person there and you never transfer the patient. And so I think particularly services that have been really limited, like neurosurgery, have gotten really good at that. Cardiology is another great one. So our air medical does lytics in flight. We get, EKGs transferred in flight as well so that we can kind of get the cath lab and we can direct based on limited resources where people go. And so those are other aspects of, quote, using telehealth. With COVID, that's even more expanded. So as a state, we bought a bunch of pulse oximeters and distributed them to emergency departments. And so you get someone who's just, not feeling super well and goes home with the pulse ox, and then they can call back rather than coming back in. So it's like minor telehealth. We use a lot of iPads now as well. And I tend to call it digitally enabled health instead of telehealth, because I don't think it has to be with a machine. It's just enabled digitally. And so what ways does that look like it's helping?
Thanks very much, Ann. I'm going to turn this over to our panelists. Juan, Sandy, Dave, one of you raise your hand to go first. Sandy, then Juan, then Dave.
Everybody wants it.
Okay, Sandy, that's like, whoa.
And first off, that was absolutely wonderful. And of course, I've heard some of this before, but you're always terrific. So I got a question. When this started, how did you get the word out? I mean, we had enough trouble getting the word out in urban areas to people that there was something different and you had to act differently. How did you possibly reach the people in Alaska?
Yeah, it's a great question. I think initially the whole world was a little bit tuned in to COVID in general. So we started to have press conferences fairly regularly. Our governor, I think, has done a great job of just letting me be me. And so we all did them together. And so when the press conference would happen, he would speak and then I would speak. And that's how we've been doing them the whole time. And so I think that was the initial way. We then, I think, been partnering with local communities. So every community, when they first had their first case, it was oftentimes me, the mayor, the tribal leader, and particularly an industry, and then a medical leader would do some joint statement. And it might be on Facebook, it might be on radio, and we kind of be like, we know this is scary, we know this is out there, this is what this looks like, and we're all in this together. And we ended up having this like template of doing that because it just really worked much better when we were all able to say, there's a lot of noise out there and there's a lot of fear and a lot of concern, but like, we got you, we're here and we all need to just work together. And so that template we started to kind of circulate and keep doing. And I think that that's helped when we've needed to like then share new information, like you got more cases or we need to change X, Y, or Z, because as their kind of trusted tribal leader, schools are playing a bigger and bigger role in that for us right now too. So we're doing lots of echoes with the principals and superintendents, and they're just doing tons of really amazing work on contact tracing and on quarantine and on educating families. And so really they are the public health leaders in most of our communities. In some of our communities that don't have a mayor, it is the school principal who's the leader. And so really connecting to the schools, I think is really important. I was on a CDC webinar recently and they said, you know, most people know who the school principal is, but they don't know who the public health leader is. And that just really rung true to me. What ways can you use other trusted leaders in the communities to partner together to be able to jointly respond to this? It's not about me. It's not about anyone knowing my name. It's about making sure people are healthy and well. And schools, I think, have been a traditionally left out part of that we need to partner with more in health.
Thanks. Let's see. I think had his hand up next. Dave. Juan.
Again, thank you so very much for that excellent presentation, Dr. Zake. Here in Eastern North Carolina, in fact, North Carolina, 3 of the 5 counties with the highest per capita COVID right now are rural counties in Eastern North Carolina. Hyde County, Pamlico, and Bertie. And it's a real shame, unfortunately, that I think the message hasn't gone out to rural America. This isn't a problem just for large cities, it's for rural America as well. And it's just a matter of when it hits. And the problem is, as you already mentioned, when it does hit, it's especially hard because of the lack of resources. The other issue that's come up in several areas, I know, is that when it does hit, it's an entire shift or an entire crew of healthcare professionals or EMS providers. And this is a real issue when all of a sudden your entire EMS agency is out of commission and needs backup, and the nearest agency is maybe an hour or more away. And so I think it really is important for agencies to think about mutual aid agreements. And the other issue is I think the message needs to go out to rural America that they're at risk as well, especially the healthcare professionals who really need to be careful about PPE. And we've noticed one of the big issues for at least our system at our hospital, which is, again, a large hospital, is at lunch breaks when people are eating meals and exposing each other during meals. And it really is important to, I hate to say, you know, folks want to socialize and eat together in groups, but we often do, and it really does put us at risk for all of us to get it at one time.
I really appreciate you bringing that up. It's the same thing that we see here in our case investigations. Almost all of our healthcare worker cases are either socialization outside of the hospital and or breaks. I mean, it's just continually where we see spread happening. You know, I think you make up a really, bring up a really good point about rural America and how no one is immune to this disease in so many different ways. I think this is also just really highlighted. Sometimes I feel like Scooby-Doo with like kind of that, you know, magic dust to see like the invisible connections between all of us. And what happens in urban America affects rural America. And what happens in rural America affects urban America. And I think sometimes we think of ourselves in these like different pockets or worlds that are somehow unconnected, but we are so immensely connected. And when I look at the genomic studies of these cases, and I can see from like a college student, you know, who traveled to Italy is now that viral case is in my most rural and remote town and village. They may never have met each other, but it just takes a few degrees of it. And so I also think that just like we think of our urban centers as our way, like they have been kind of our traditional hub for protecting and for having that healthcare, keeping it out of our urban areas is also really important for keeping it out of our rural areas. When we see cases spike in Anchorage or in Fairbanks, we inevitably a couple weeks later see them spike in our more rural areas. I also think we need to use geography to our advantage. And so what ways when people are coming in and out of geographic areas, what ways can we take advantage of that and not just have it be our limitation? And what ways can we spread out? What ways can we use, you know, community, and what ways can we kind of test and be able to screen? And part of the reason we're spending a lot of time and money testing anytime you come into our state and or any other place is like, okay, we're far away and it's a bummer because we don't have ECMO, we don't have all sorts of other things, but we can test you before you come in because you can't get through Canada. And so how can we use that to our advantage? Because we've got that and we don't have other things.
Thanks, Ann. Dave?
Yeah, and that was wonderful. A couple of questions in 2 different areas. One is, you know, bandwidth and broadband in rural areas has been a real problem in a lot of areas. Has that been, sounds like you've got a well-established network, but obviously the distances and things break. That has to be a challenge. So if you could talk a little bit about that. And the other is, for emergency physicians, is there one thing that you think emergency physicians need to know about getting involved with public health?
Okay. Well, okay. I'll take the easy one first. Broadband. Yes, really, really hard. And many of our communities don't have it. And so A lot of the schools have it. And so some of the health clinics were set up outside of schools. Our testing sites were set out of schools. So like the Abbott could upload it. So we kind of use that outside school space. Most of our alternative care centers were set up in schools as well, because it was like the one place that had internet. And they set up kind of like stations for kids to learn or for healthcare providers to be near there, just because it was our one access. I think it's also important. I mean, we've all gotten good at this right now, like turning off our video to save broadband, but like the phone is a really successful part of digital health. You don't have to have like some fancy computer. And so particularly like what we're doing for neurosurgery, it's just pushing the images. And if that is done asynchronously, that's okay. And then you just call and have that conversation. And so I think that we can do a lot more without having super big broadband, although I would love more of it to be able to move forward. So finding what is good. The radio, FM radio has been huge in a lot of remote areas. So a lot of my messaging and stuff is on FM radio, because that's how people get their messages and information. And so using some of those kind of traditional, kind of old school techniques of getting communication has been important. For what is the one thing I would recommend? I mean, if you're an emergency physician, you're doing public health. Like you are doing it every day, all day. You're just doing it and not always able to affect change in it. So why not do it and come affect some change and make the policies that drive you nuts better? I would just say you've already chosen public health by choosing emergency medicine. And just like you keep up on the literature of cardiology, or you keep up on the literature of, you know, how to treat a PE, keep up on the literature of what makes sense to, you know, the social determinants of health and what's, you know, keeping that person healthy and well in their communities. Before I kind of got into public health, you know, I was, you know, I fixed an arm. I took care of, you know, when someone came in for COPD. And now almost every patient, I find myself talking about like adverse childhood experiences, or I talk about, because it affects all of my patients in some way. And it gives me this whole other skill set and language that I didn't know I had and didn't know my patients needed. And it makes my job in the emergency department so much more rewarding, where I can meet them where they're at and really give them useful tools, instead of just saying, I don't know why you have chest pain. I don't know why you have shortness of breath. Go follow up with your primary. I mean, that's a non-answer to me in so many ways. And so I would say you've already chosen this. And so just learn a new language, because your job will be more enriched and fulfilling if you do.
And thanks for commenting on that, like the intersection between public health and actually, I'm not sure it's like a Venn diagram. I think that's like a direct overlap, which I think is what you just said. I'm just paraphrasing what you just said. So one specific question, then I want to go to the polling, and it is about testing. And there's this, like, Alaska seems to be crushing it on the testing front. One problem I see in a rural hospital in my area, it takes up to 2 weeks to find out test results. How long is it taking on average to getting a test result from Alaska?
I don't want to say publicly, because I feel embarrassed in some ways. I mean, yeah, I mean, it depends on where you're at. The biggest thing is the turnaround time it takes to get the swab to a place. So our state lab is really a 24-hour turnaround, and we're putting out about 3,000 a day right now there. We do have some contracts with some out-of-state places, but you can see on our data dashboard, based on region and location, what commercial, facility, and state lab turnaround time looks like. So it's all public, it's all on there. I really have come to believe that this is not political. This is about citizen scientists wanting to do shared decision-making. And if I can put it in that context and framework, it's a much more productive framework for me. And so what ways can I do shared decision-making with patients? And so we put up the turnaround time. So it's about 2 to 3 days, I would say, on average across the state, no matter where you're at. But that varies significantly, with some communities really being able to do point of care Abbott testing. But if it's more than 3 days, something's gone awry. It's either an inconclusive or something's gotten stuck in the IT world of getting information back, and it's too long. So if I'm hearing a week, or 5 days to a week, then we're case by case trying to problem solve what happened to that one.
Thanks very much. And it's a great presentation, great discussion. We're going to go to the polls and to the polling questions. And when we do the polling, it's like 12:50. It's about 6 polling questions, six or seven polling questions. Everybody will see the results of the polls in real time when we get done with those. And then we'll go around for some really quick last comments by our panelists. And then, Ann, you get the last word for sure. Okay. All right. So Echo, if you can put up the first polling question, that'd be great. They're all, almost all these polling questions today are ones that we have done in the past, and it's trying to get a feel for where we are today compared to way back, like for instance, in April or May. In your emergency department today, which of the following PPE supplies are you most short of? It's a pretty straightforward one. And also for each of these questions that are popping up, at the bottom of the options is I am not an emergency department provider or leader. So everybody has the option or the opportunity to vote, okay? And the more, the better, obviously, with any kind of polling like this. 51% of you voted. We'll stop in about 5 seconds. All right, let's go ahead and stop there. 54% of you voted. And lots of you not emergency department providers and leaders, not unexpected. That's the way all these are. We have a diverse audience for sure, but not short of, it's kind of like phenomenal, not short of any PPE, 21%. Then it looks like N95 masks, 14%, and then gowns, 8%. Thank you. Next. All right, this is one about where you're going to work in 6 months' time. In the next 6 months, and this is only for emergency department care providers and leaders, so we should see the same numbers in terms of those that aren't in the emergency department care. So let's see what these results show up to be. Echo the graphs that I shared with you prior to starting. We'll do those after the polling results quickly. All right, another 5 seconds. 58% of you voted. That's great. 60%. All right, let's stop there. All right, that's pretty remarkable. Most for sure said plan on working at the same place I am today. How about that? All right, let's do the next one. And the next series, there's 3 of them. These were also asked for critical care, ICU docs and nurses and respiratory therapists on Tuesday's rounds. So these are exactly the same questions, but trying to like really focus on discipline. And this obviously being emergency department rounds. So this is about mental health of emergency department staff. Have 51%, another 5 seconds or so. All right, let's stop there. 57% of you voted. That's great. Better 6%, same 15%, worse 14%. And interestingly, those results are similar to what we saw to that question for critical care providers and leaders. Next, they're very similar. I don't have the exact numbers, but very similar to what we saw on Tuesday. Okay, this one is about fatigue for emergency department care providers and leaders. About 55% of you voted. All right, let's stop there. 55% of you voted. And 27% said more fatigue, the most common response by emergency department care providers and leaders. And that absolutely parallels what we saw with critical care providers as well. So yeah, very close. Next. We're going to do EMS on EMS rounds on next Monday, the same questions too. See if there's similarities, differences. For emergency department care providers, leaders, this is about complacency as opposed to fatigue. I really appreciate participants jumping on these. You've gotten so, I mean, it's for the round, you know, having 50% response to anything is pretty remarkable. So really appreciate participants jumping on these quickly. All right, let's stop there. 54% of you voted. This one, you can see it right along with me. This one's a bit different than critical care providers in that the responses by critical care providers didn't indicate there was, didn't have it so that more was the most frequent response. I don't recall the exact number, but there's more of the more responses for emergency department providers and leaders. All right, thank you very much. I do want to go back, echo to the charts from previously that I had. This, I want to go back because it's sort of like we've done these before, but I felt it was probably worth sharing what the results that we had from previous questions on the previous PPE shortage and future work plans. So the first graph that you're going to see is the same question we did on PPE. Yes, it's really small, and I'm sorry. But back in April, it looks like gowns was the most frequent shortage in the emergency department, followed by N95 masks, not short of any PPE, 27%. So that huge changes from April to today's polling results for sure. And then let's go to the next one. This was the whole issue of where you're going to work in the next 6 months. This is, these are responses from May, back May 14th. We asked the same exact question, and the most frequent, the order is not quite the same, but if you take a look, the most common response then was for sure, I plan on working at the same place I am today, like 90%. So yeah. Anyway, interesting to see how things have changed in the past 6 months, 5 months. So with that, I'm going to go around to each of the panelists, and then Ann, any final comments? Juan, why don't we start with you?
I think we, as healthcare professionals, really need to get the word out in regards to rural America, that they too need to prepare for COVID because it is coming to them. Again, it's not just in big cities, it's in rural America as well.
Yeah, Juan, and based on what I see with HHS reports, what it's like. Yeah, if there's ever a moment in time when docs and nurses and healthcare professionals need to like yell loudly and clearly, it's right now. Sandy?
Me? Did you say me?
Yep. Yeah.
Oh, I'm sorry. I didn't quite hear. I heard.
Yeah. Sorry. It's okay.
I took away, I have a slightly different message, and that is I talk to a lot of mid and later career emergency docs who are like, you know, I'm getting tired of just doing the same old thing. Look at Ann. Not that you're an old, but, you know, mid-career person. There are so many other things that we can do with our skill set. If you don't like what's going on, if you don't like the policies that are there, as Ann said, then change the policies, get in a position and change it. Look at Rick. There are some really amazing things that we can do with our skill set.
Yeah, Sandy, I appreciate that. I just want to caution those that just heard that. You might want to talk to me before doing federal service. That being said, what Ann's message and Sandy's on the public health intersect. I mean, it's absolutely the case. I mean, emergency medicine is doing public health. I mean, it's what you do. But what I heard from you is exactly where I was a few years ago, where I just got tired of the horror, tired of the horror. And, one patient at a time was insufficient. And that's what certainly has led, not just me, but many others to do much more with a patient within a patient at a time. Sandy, you got another comment?
Yeah, when I talk to people about what people like Ann and you, and to a much lesser extent me, I talk about, we spend so much of our career doing one patient, and now we can change things for a region, a state, even nationally. And so I think there are a lot of other things that one can do with our skill set. If you're happy being an emergency doc, by all means, but there are some other things one can do. We're an incredibly bright group of people.
Yeah, thanks, Sandy. Dave?
Yeah, just a couple of things. I think, we talk about complacency, which is sort of I think an indicator of mental health kinds of things and your own internal resilience. And as we talk about rural areas start out with not having the resources to do good mental health. And I think this pandemic is going to just make that even worse. And even in the urban areas, we don't have nearly the resources we need. So I think that's one of the things that for folks like Ann, who's at a state agency level, to really try to figure out ways that we can support that mental health function is going to be really important.
Yeah, thanks, Dave, for your comment. Ann, last word for sure.
Great. I really appreciate the questions, the comments, mental health. I also want to just shout out to all of those on the front lines. Harry, I know you're there, and many others right now with the fire. It's been earthquakes and tsunamis and hurricanes and fires on top of COVID. And I know that is challenging us in all so many different ways. And so just special thanks and shout out. The one thing I just want to mention is that, I remember early on when Dr. Messonnier said, think about what this might look like if your public transportations go down, if your schools go down. And for me as a public health official, I was like, oh, okay, that's big. I guess I got to think about that. And recently, it was actually a couple months ago, someone said, think about what this pandemic is going to do to change healthcare fundamentally moving forward. And I think that was another moment. And so I would guess I just challenge each of you to think about what ways do the challenges we have, the fires, the earthquakes, the hurricanes, the COVID in our world, how can we take that and look at the positive on that instead of the utopian or dystopian view, take the utopian view and figure out what can we fundamentally change in our delivery of healthcare to make us all better and healthier and more well. And I think if we focus on that, just like driving a motorcycle, you go where you're looking, let's look at that and let's drive this healthcare change to a better place.
And Ann, friendly amendment to that. If the people who participate on these rounds, healthcare providers, are not leading that charge, you have lost the way. Leading the charge with those fundamental healthcare changes is going to be absolutely critical to take care of your patients and yourselves. It's absolutely going to be critical. So anyway, yeah, it's an editorial comment, but yeah, I said it. Bruce, your comments?
Well, one, Ann, thank you. I heard you speak 2 weeks ago on the Native American and Rural Health virtual conference. And your talk then was super inspiring, which made me tell Rick, we need to get Ann on these clinical rounds. And so it was fabulous that happened in less than 2 weeks. So just fabulous to be able to have you share your experience and messages from Alaska nationally with a whole different audience. And I think reading through the comments in the chat, you've inspired a lot of people here as well, who I think will take that inspiration and run with it. So thank you. Thanks for joining us, and take care and keep leading the charge in Alaska. And now you've got an even bigger platform. So join us, please. Come back, and you have an open invitation. Everyone who speaks on these gets to come back whenever you want.
Awesome. It's been an honor. Thank you so much for the opportunity.
Yeah, thanks, Ann. To our participants, you're heroes in your own rights. And like Ann said, people are dealing with, it's not just COVID, it's double disasters, protests, wildfires, the tsunamis, and certainly the hurricanes that, Juan and Dave just went through. And now I'm sure there's other ones brewing out there with some unnamed name. And and to our panelists, hey, Juan and Sandy and Dave, thanks for joining. Your comments really help stimulate some really important discussion. And Ann, clearly you got a fan club, and I have joined for sure. The final comment before I sign off. The mental health, the fatigue, the complacency, the break room conversation that we've had. As I've mentioned on rounds previously, we report out on what happens with these rounds to HHS. You see the results of the polls, and they do too. And as a result of the one we did on September 1st with deaths of clinicians, that went beyond HHS leadership to leadership in the government. And there's some new attentiveness to that I appreciate everybody's sensitivity to, and would certainly encourage you to take a look at the September 1st rounds on deaths of clinicians. It's an important message for all of us. We got to take care of ourselves, as I've said, and we've taken time off on rounds to be able to support our mental health, and you need to take time off. Take care of yourselves, and Ann, seriously, from my heart, appreciate your being here, and thanks all. We'll see you on the next one. Bye.